Everybody, and welcome to our webinar on menopause and brain health. My name is Jared Kelfi, and I'm the State Advocacy Director for AARP Virginia. We really appreciate you joining us this evening. We've got a great program for you, as you're going to hear from some experts in this field, and then afterwards you'll have an opportunity to ask any questions that you may have. So as we go along, just drop your questions into the Q&A. The chat is disabled, so make sure you put your questions into the Q&A, and we will get to them in the final portion of the webinar. And with that, I am going to turn things over to Lindsay Churro, who will be running the show tonight and introducing our guests. Lindsay joined AARP in 2015 to serve as Senior Policy and Research Advisor and the Chief Scientific Officer for the Global Council on Brain Health. She received her doctorate in psychiatry from the University of Cambridge as a Gates Cambridge Scholar for her research that focused on structural neuroimaging of the brain. Prior to studying in the UK, Lindsay was a Fulbright scholar at a clinic in Australia specializing in reproductive medicine. So quite the impressive resume. Lindsay, take it away.
Thank you so much, Jared. It's really a great pleasure to be here. It's a long-awaited webinar, and we're so happy to be joined by Dr. Joanne Pinkerton and Dr. Dana Reddick. Some background about Dr. Pinkerton is she is the endowed Women's Midlife Health Professor of Obstetrics and Gynecology at the University of Virginia, as well as past president and emeritus executive director for the Menopause Society. She is a certified menopause practitioner, fellow of the American College of Obstetrics and Gynecology, and founder of the UVA Midlife Health Program. She has led over 30 clinical trials and published more than 175 papers. Dr. Pinkerton is the founder and division director for the Midlife Health, one of the few centers in the country that specializes in caring for women 40 and beyond, and has been active in research about menopause and teaching. And she's joined by her colleague, Dr. Dana Reddick, who is an associate professor in the Department of OBGYN at UVA School of Medicine and a credentialed menopause specialist through the Menopause Society. She joined UVA in 2002 and now works in the Midlife Health Group, where she focuses on menopause with an interest in uterine fibroids and office-based gynecological procedures. Dr. Reddick served as co-PI and mentor for a recently completed and presented trial on improving pain relief for IUD insertion. Dr. Reddick is involved in medical education at all levels and currently serves as Assistant Student Affairs Dean for medical students in the UVA School of Medicine. So as you can see, this conversation will be very rich, and we're just so delighted and honored that both Dr. Reddick and Dr. Pinkerton agreed to join us for this very important webinar. Thank you, Jared.
Are you okay if I go ahead and share slides and get started?
Sounds great. Please do.
Okay. There we go. All right. Did that come up for everybody?
Yes.
Excellent. Thank you. Well, thank you so much. Was such a generous introduction, and wonderful for me to get to share this with the AARP and also with Dr. Pinkerton. I'm going to get the kickoff and talk a little bit at the beginning about menopause in general, and then about halfway through handoff, and Dr. Pinkerton is going to focus a little bit more on the idea of menopause and its impact on aging, on the brain, and cognition. So with that, we do want to start with some disclosures. We will be reviewing medications, both FDA-approved indications and then some non-FDA approved, or what we would call off-label. We are both members of the Menopause Society, as noted, and certified practitioners. This presentation will include a number of pictures, articles. We work pretty hard to reference that so everyone can see, and we have some other consulting activities. So the definition of menopause is when you go a full year without a menstrual cycle. But your ovaries don't have a polite retirement party. That process happens over several years, and we term that kind of time frame perimenopause. As you look at this slide, you can sort of see most people have an ovulatory cycle. They have a once a month period. And when you're many years out, so 9 to 10 years out from menopause, most of your cycles are going to be ovulatory. They're going to be those regular, predictable, once a month cycles. As you get closer to the time where your ovaries stop making hormones and you stop having periods, an increasing number of those cycles become anovulatory. And what that means is that your periods can become unpredictable in their interval. They can be heavy, they can be light. And along with those changes in your menstrual history, people have lots of other symptoms. This list hits a large number, but I can say there's probably some even beyond this that people experience, from hot flashes to poor sleep, mood changes, impact on concentration and attention, urogenital changes, so those are things related to the bladder or the vagina, just a generalized kind of joint pain, not one joint, but sort of more kind of achy all over. You definitely see some weight gain and redistribution of weight. I always say it feels like it all goes right in the middle, as common. We see some more feelings of bloating and GI changes, as well as some headaches and musculoskeletal pain. And you can see hot flashes are that classic symptom, and many women experience this. A lot of people ask, like, what's the cause or source of hot flashes? And I won't say we know it down to the detail, but we have a much better understanding of hot flashes. And it has to do with our normal thermoregulatory zone. So there's an area or a range of comfort that we have where we can be a little hot, a little cold. And that range or that thermoregulatory zone where you feel fine narrows as there's less estrogen in the system, in that sort of thermoregulatory zone of the brain. And so when before you might have been comfortable at a particular temperature, because that zone has narrowed, all of a sudden that could trigger you to have a sweat or a chill. Oftentimes people ask, like, why are my hot flashes worse, or why do I have them and someone doesn't? And we've looked to see what maybe some of those risk factors might be. And we know that smoking is a risk factor. African American or Black race is a risk factor, as well as socioeconomic status. And interestingly, a lower baseline mood or difficulties with anxiety, depression to start may actually worsen the severity of your feelings of hot flashes. Expanding a little bit on this concept of race, they've looked, and the duration of how long you experience these vasomotor symptoms seem to be different across that line as well, with Black women suffering the longest time with hot flashes. I think the other thing to know is that this is very time dependent. We see the most severe symptoms as people enter that perimenopausal time, that you're sort of approaching that final last menstrual period, and then in the early part of menopause. Gratefully, as we get beyond that initial menopause and you get older, most of these symptoms improve. And this is an improvement even without treatment. This is something that sort of improves over time. And I think one of the other things is that I emphasize the importance of making sure you have the right diagnosis. Most of the time, you can follow someone's menstrual history, you can match it with their age and some of their other, and you know, oh, these symptoms are coming from menopause. But occasionally there are some other unusual reasons that people have flushing or hot flashes. So it's important to bring this concern to your physician, have them evaluate you. It may be appropriate to get labs. It's not required to be able to make the diagnosis to check labs, but I've included some of the ones that are commonly done here because your thyroid sometimes can make you feel hot or cold, so you want to make sure that's normal. And there are some other hormone levels that we might check as well. I also want to emphasize the importance of continuing to attend to your general health, having attention to your diet, your activity. All of these general health things are going to help you through the menopausal transition, as well as not ignoring some of the other attention to cardiovascular risk, bone health, and routine cancer screenings like your pap smear or HPV testing, mammograms, and colonoscopies. I think this graphic is really helpful to sort of put in context. I think sometimes we have a fear of a certain thing, whether it's dementia or whether it's cancer, or whether it's heart disease. And this graph kind of lays out, as you look at age, the proportion of heart disease increases, and the cancer risk seems to kind of peak a little bit in that 60 to 70 range and then go down over time. When I'm talking to patients and when Dr. Pinkerton is talking to patients, the foundation of anything is to start with that really attention to general health. And we're going to go through that again. These are things that all of us know, right? We need a good night's sleep. We need to eat a healthy diet. We need to work on reducing the stress in our lives. These things can help with the menopausal transition. Then you can also engage in sort of other like cognitive behavioral therapy that can help with menopausal symptoms. When you're specifically looking at hot flashes, acupuncture, and paced breathing, these are some techniques that can help with that. Many people turn to non-prescription or what we would term over-the-counter treatments. These are supplements, these are herbal preparations. I think one of the challenges in this space is that they're typically marketed as a nutritional supplement. So they're not required to prove effectiveness. And so it's hard to recommend one particular therapy out on the market. We will, when we're in the talk, we can talk a little bit more about nutrition in the Q&A if people do, but we also talk about vitamin D and calcium and those things for general health as opposed to addressing specifically menopause. We also have options. We're going to get to hormones at the top, but we have non-hormonal options that help people in the transition. There are folks, and we're going to hit this in the next slide, that aren't candidates for hormones, but that does not prevent us from helping them with their symptoms with some non-hormonal treatment options. And then the final, we're going to talk a little bit about hormones. So are you a candidate to initiate starting menopausal hormone therapy? Our guidelines, and you can see this is from the North American Menopause Consensus Statement on Hormone Treatment, is that you should be under the age of 60 and within 10 years of menopause. You should be symptomatic. You shouldn't take hormones just because. You should be taking them to treat symptoms. You may consider it if you're thinking about bone density concerns. You also want to make sure there's no contraindications, and that oftentimes includes a high risk for cardiovascular disease or breast cancer. So just to share some specific things that would say you should not start menopausal hormone therapy. One would be if you're having unexplained vaginal or uterine bleeding. That needs to be evaluated and addressed before starting. Folks with liver disease, if you have an estrogen-sensitive cancer, then you wouldn't want to start on estrogen therapy. And this most commonly is in the category of breast cancer, but there are other types of cancer that are estrogen sensitive. If you've had a prior heart attack or a stroke or any type of blood clot in your leg or your lung, these will be reasons not to start. And part of the reason is that estrogen can increase your risk for blood clots. And so we want to be mindful not to start hormone therapy if you've had any of these before. And even without these absolute contraindications, sometimes hormone therapy can have some side effects. And that's where working with your provider to get the right regimen is very helpful. So a lot of people say, well, what should I take? When we talked a little about who should start it and how long I should take it. When we talk about menopausal hormone therapy, we're usually talking about estrogen and progesterone. The progesterone counterbalances the estrogen in the uterine lining. That keeps it, if you take just estrogen, that lining can be stimulated and over time at risk for developing hyperplasia or cancer. Whereas if we provide progesterone or an estrogen blocker, that risk goes down. Testosterone is not typically part of the standard treatment, but it has been shown to be helpful for hypoactive sexual desire disorder, and so may be added to your estrogen and progesterone. You can also use local therapies for vaginal dryness and bladder symptoms that aren't going through the whole system. For providers, we think very carefully about who should start, how long they should start, and adjustment, and that's a personalized risk-benefit discussion that you have at the office. You may extend therapy based on bone loss prevention, quality of life, or other things. So there's no one set age that is the time you're supposed to stop hormones. And I have a cue here. I'm going to stop sharing, Dr. Pinkerton, so you can pull up your slides and do the second half here.
All right. Can everyone hear me? Dana, can you hear me? All right.
Yeah.
So Dana, thank you so much for, giving us the background. I want to really stress that menopause is very important to learn about for health. It's a life stage. It's not a disease. It's a critical window for prevention and care, and it's linked to an increased risk of heart disease, bladder and vaginal issues, osteoporosis, and cognition and mental health, which is what we're really focusing on today. But as you go through menopause, as your estrogen levels change, it really becomes important to think about all of the different effects. And this slide just really shows you that you have estrogen receptors throughout your body and that it can help your cholesterol. It has an effect on your breast. It has an effect on your uterus. Dr. Reddick has talked about that. There may be some anti-aging on skin. Definitely women who have less estrogen have less bone density. It affects the liver. And we saw a question in the chat about doesn't transdermal prevent heart disease, and what if you take an estrogen through the skin, it avoids the second pass through the liver, so there's less blood clot and stroke risk. And then for brain, that's what we're really talking about today. And 40 to 60% of midlife women experience cognitive symptoms. That means that if you are forgetting, having to do a to-do list, if you walk into a room and you'd have difficulty recalling a name or a word, or you have to say a workaround word, if you have trouble staying on track with the task of conversation, difficulty focusing, if you feel mentally foggy or sluggish, like your brain's just not quite up to speed, maybe have a reduced ability to focus or concentrate for long periods. But it's very important to know that dementia-related cognitive symptoms are very rare at midlife. And if we see them, referrals for neuropsychological testing would be reserved for people who have reporting severe or frequent symptoms. So I had a patient who had been a physician. She had a health issue. She stopped working, but then she said, I'm really having to make lists to do everything. And we just thought it was menopause. Maybe she needed hormones. A few more years go by. And then she says, I really, my husband is now giving me my medicines, taking care of things. I went, wait, this is more than menopause. And that's when you think about doing referral for the neuropsychological testing that they do. So 45% of current cases of dementia are attributed to lifestyle and environmental risks. It's not all about what's in your family. And so the same things that Dr. Reddick talked about for your general health are really important for your brain. That healthy lifestyle, regular exercise, healthy diet, stop smoking or don't start, limiting alcohol consumption, and address hearing issues, because all of those things affect your brain function. And this is from AARP, and it's the 6 pillars of brain health. And I do want to go through these. Being social has turned out to be really important. Keeping in touch with friends, not being isolated, being part of a bridge group, being part of a musical group, doing plays together, engaging your brain, finding new ways to stimulate your thinking, new hobbies. Who would know that they have, cruise ships for quilting where everyone not only is making and learning new things, but they're sharing it as a group. Managing stress, practicing relaxation, taking time for yourself, doing cognitive behavioral therapy, or anything that can help you start to manage the stress. Ongoing exercise, they want us to get about 150 minutes or 2.5 hours a week of moderate physical activity. And I'm going to say that that needs to include strength training, 7 to 8 hours of restful sleep every day, really working to get to bed on time and making sure that you've got quality sleep, and then, being heart healthy. And what I heard this morning was that being out in the sunshine for 15 minutes also helps prevent dementia, also because it helps maintain your vitamin D levels. And then just the other thing is just if you have lost track, if you're not doing any of these things, don't beat yourself up. Just take small baby steps and get yourself going again. So, and beyond that, we really work on sleep hygiene because you can train your brain to sleep better. But if you have persistent sleep issues, you may need a sleep study. You could have restless legs, you could have sleep apnea, or maybe you need some medications. And then looking at medications and how they might affect your brain and your cognition. Sleep aids, medicines like Ambien are not actually very good to take on a long-term basis. And these specific medicines called anticholinergic meds, they block the action of acetylcholine. It's a neurotransmitter that sends signals between nerve cells. And so when you have medications that cross the blood-brain barrier, they can be associated with later dementia or cognition. Some of the ones we worry about are Benadryl, oxybutynin, and tolidine. Those are last two are used for overactive bladder, and using them a short time for specific reasons not an issue, but you really want to avoid being on those medicines long term. And the good news, at least for overactive bladder, is that we have newer medications that don't cross the blood-brain barrier, so they don't have that same risk. And then if you're having vasomotor symptoms, hot flushes and night sweats, we need to address them either with hormone therapy, or we now have these new, very effective non-hormone therapies treating high blood pressure, diabetes, and depression. Those are very important. And I always tell people, know your numbers. What's your blood pressure looking like? What's your lipids? What's your glucose? And you can go beyond and get specific lipid tests. You can get, the hemoglobin A1C to see if you're pre-diabetic. You can ask for a coronary CT scan to see if you've got any calcium in your heart vessels. So being assertive about taking care of your health. What's a couple of practical tips when you're feeling foggy or tired or not concentrating? Well, notes, lists, and reminders. They have shown that taking notes by hand in a journal actually helps you remember things better. You can quiz yourself or explain new concepts to someone else. We always laugh about see one, do one, teach one, but it turns out that the teaching part of it is what actually gets it into your brain and puts it into long-term memory. A challenging new cognitive activity, a new language, a new instrument, bridge. You can work or volunteer in an intellectually challenging occupation so that you're learning new things. And it's really important to maintain that social connections. Well, what about estrogen? What is happening with estrogen's role in the brain? Well, the brain is very rich in estrogen receptors, and they help regulate memory. And the decline of estrogen during perimenopause changes actually neural connectivity. It reduces processing speed and verbal fluency, i.e., you're not crazy if you think that you have brain fog or difficulty remembering words. And the female brain is uniquely sensitive to estrogen. And that's why declining hormones at menopause and midlife cause these changes of brain fog, memory lapses, and potentially a higher risk of Alzheimer's disease. And this is a slide, and Polly Mackey had shown this, which is showing the different estrogen receptors before menopause and after menopause. And the bright colors are where those estrogen receptors are. And you can see that they shift over time. And that becomes important because hormone therapy at menopause helps maintain those receptors. But when you start hormones far away from menopause, you've already made different neural connectivity or different rewiring of your brain. Well, what about menopause and brain health? When you go across the menopause transition, they've shown that women do have reduced scores on tests of verbal learning and memory changes, but they're time limited. They don't rise to the level of impairment. And the mechanisms of hormone influences on cognitive health at midlife are not completely understood. The good news is we have researchers working on this, and we have these functional brain MRIs that are giving us a lot of information. We know that estrogen supports the health and the function of memory, and the loss of estrogen means the loss of that support. You have to recalibrate, rewire the brain, and that's what happens over time, which is why these memory changes associated with menopause don't persist, and they are not markers of dementia. And the scary thing that many scary things came out of that Women's Health Initiative study that was initially published, the increased risk of breast cancer, heart disease, stroke, blood clots, and probable dementia. Well, first of all, probable dementia is a diagnosis. It doesn't mean that you're probably going to get it. But what they found was that when they started women, initiated hormone therapy at women 65 and older, they found that if you look at that slide on the right, that those on placebo had less risk of getting probable dementia than the people taking estrogen and progestin therapy. And interestingly enough, they did MRIs on some of the women, and the women who already had that white matter changes in the brain happens with age, but if you had more of that when you started these oral hormones, it actually increased the chance of developing dementia. Now, the issue really becomes that we don't now start women at 65 or 70 on hormones, and we wouldn't start it to prevent dementia. So what about hormone therapy? Does it help or hurt your brain? Research doesn't support the use of hormone therapy for cognitive preservation or dementia prevention if you undergo menopause during a normal age, which is 45 to 55. And I'm saying that despite the influencers who are telling you that if you take hormones, it will prevent dementia. The studies don't show that. However, hormone therapy may indirectly affect cognition because it reduces hot flushes and night sweats, and it improves sleep, particularly that rapid eye movement, REM sleep, dream sleep, and you have fewer sleep disruptions. And there's some data that just having persistent hot flushes may be associated with white matter changes in the brain, as well as markers of cardiac risk. So treating those hot flushes at menopause is very, very good for your health, as long as you don't have any of those contraindications that Dr. Reddick talked about. For women who have early menopause, less than age 45, and particularly if they've had their ovaries removed when they're very young, we have been able to show hormone therapy may reduce cognitive risks. And you might say, well, the hormone therapy we use today is not the hormone therapy that was tested. And that's true. But we do have a study called the ELITE study, where they took women at menopause and had them start hormone therapy either at menopause or 5 years later, followed them for 10 years. And the best we could tell was that we didn't harm cognition, but we couldn't prove that we prevented it. Now, the other issue is Alzheimer's might not start for 20 years. So it's really hard to prove that something we do at menopause is going to clearly prevent Alzheimer's, but it is good for your health for most women. And we look at it as really a critical window, a window of opportunity of estrogen therapy for neuroprotection, because there's a proposition that estrogen could bring greater benefit to a woman who starts it in her 50s while having a reverse effect if you started at 65 or 70. And so you'll often hear that we recommend hormone therapy to be started at women who are under the age of 60 or within 10 years of menopause. But we don't recommend starting it in women who are older, particularly 65 or 70, because we think that increases the risk, mostly because they already have changes going on in their brain and in their heart vessels that then get exacerbated by the hormones. And so we don't offer it for prevention of Alzheimer's, but we have a lot of reassurance that it is going to help sleep and mood and hot flushes and may have a benefit for the brain. So I wanted to talk about, if you're saying, what are the good things? What helps you have preserved cognitive function? Well, lower ages, less reported forgetfulness. People who report forgetfulness may test that they do have memory issues. Good physical function, optimism, having healthy hemoglobin A1Cs, low blood sugars, sleeping better, higher education or challenging environments, low blood pressure, and less depression. And then as you age, this is what happens. You have aging, which all of us go through. And by 80, all of us are going to have some degree of memory impairment. But abnormal aging is then diagnosed initially as something called mild cognitive impairment. This means that your brain isn't working quite as well as it should. You might be slower, you might have more difficulty with driving, but you're not actually being diagnosed with dementia. Dementia is when you clearly reach that point where you shouldn't be driving, where you have difficulty functioning, and it's a progressive problem. And there are different causes of that. So Alzheimer's is the one that we think the most about, but you can have vascular dementia, something called Lewy body dementia, frontotemporal dementia, and other pathologies. And the good news with Alzheimer's disease is there's so much research, and it looks like we're going to have a blood test that can actually tell if we have some of those tau proteins, so that we can get women and men started on medication at a much earlier time to prevent those progressive changes. So what's really going on for women who have a genetic risk? Well, it's a combination of things. And at the middle, you want to have cognitive resilience. You want to bounce back. If you get exhausted in your sleep, you want your brain to be back to functioning normal. But things that might be apart might be certain protein profiles. Inflammation just isn't good for your body in general and isn't good for your brain or your heart. Markers of Alzheimer's disease, as we can measure them, and then metabolic factors. There's no doubt that having diabetes, prediabetes, poor blood glucose control, all of those do affect how your brain is working. So what are things that are not red flags, what I call yellow flags? You're running late, you can't find your keys, you don't know where you put them. Oh, they're buried in your bag, of course. You walk in your living room to retrieve something important. What was it I wanted? I can't remember. A few minutes later, oh yeah, I was looking, to get my purse. I can't find, I pulled into the parking garage. I was in a rush. I parked my car. I come out, I can't find my car. I wish I had an AirTag. And you didn't take a video or take a phone picture of where you left your car because you were rushing, you weren't thinking about it. Or an acquaintance greets you in the grocery store and says, "Hello, Dorothy, I'm so glad to see you." And you're like, "Hello, Dorothy, I'm so glad to see you." Except you don't say Dorothy, but you go, "Hello, I'm so glad to see you," because her name escapes you. And then 5 minutes in the conversation, you go, "Oh, Carol, and in your brain, you're going, I do remember your name. I do remember your name." So those are not red flags. Those are normal. Made worse if you don't sleep or alcohol. So what are red flags? If you get lost while driving, if you have trouble following a recipe, you can't do the steps in order to make the meal come out. If you keep asking the same questions repeatedly because it's not going in, you're not processing what you're hearing. If you have difficulty paying bills or mistakes paying bills, and usually these symptoms are present for a while, it's not an acute onset. And one example, and this really came out of taking care of my father who developed dementia with age, was if a person was alone on a domestic flight going across the country and the trip required a layover with a gate change, would they be able to manage that kind of mental task on their own? And you just have to say, if that answer is not likely, that would be a red flag. So this is one that drove my dad crazy because every time they came to check on him, they made him draw a clock, and the first clocks looked like the ones on the left. And so the time was really, I guess if I write, I can't quite tell, but maybe we're talking about 10 minutes after 10. So at the two. If you then look later on, maybe 6 months later, they've got the marks. They know there's hands. They can still draw the numbers, but they can't really remember what 10 minutes after 10 is. And then when they're really getting bad, you see they remember that there's some numbers and they can write them, but they don't remember that they're supposed to go all the way around the clock, and they don't remember to put the hands on. So, in conclusion, menopause and fluctuations in estrogen affect sleep, mood, memory, migraines, and cognition. Selective use of hormone therapy may be very helpful in women, particularly if they're having hot flushes and night sweats, mood or sleep issues, or migraines, but shouldn't be used for the primary reason to prevent or treat Alzheimer's disease. And there's this critical window theory that hormone therapy is beneficial at menopause, particularly if you start it under age 60 or within 10 years of menopause, but accelerates dementia in older women because of those aging neurons. And they did a study with rats, and they put dendrites in a little one of those little cups, cells, and they flooded it with estrogen, and the dendritic activity got bigger. They made more contacts. They then took dendrites from aging rats, put them in the same cell, and flooded them with estrogen, and they actually got smaller. And so that's one of the pieces of evidence that says hormone therapy at menopause good, hormone therapy in aging brains probably not good. So we have a lot of resources that will be available to you. Some of them are coming from the Menopause Society. That's our guidebook on the left. And we also have NIH has a section. AARP has great sections on both cognition, menopause, and the brain. And then the Pause Life has a blog about weight for women who are worried about that. The Office of Women's Health now has a section on menopause, and Let's Talk Menopause is dedicated to midlife female health and has articles on brain fog, podcast, and NIH has a whole section on hot flushes, what can I do? And with that, I want to pause and just thank you for this opportunity for Dr. Reddick and I to discuss the effects of menopause and aging on the brain, and we now welcome your questions. And I'll stop the share.
Thank you so much, Dr. Pinkerton and Dr. Reddick, for those very comprehensive overviews. I know that our viewers will find that to be very helpful and really aligns with a lot of our engagement work through AARP as we seek to empower and inform our audience to understand what questions they can ask their providers as they may be experiencing all the different things that you described. So we will be transitioning into the Q&A, and we have been receiving audience questions, and so we encourage you to write in more. We'll start with a question for Dr. Pinkerton, and that is, can you please let us know with regard to cognitive abilities? Will a person's cognitive abilities be impacted after menopause no matter what?
Absolutely not. If you've ever heard Margaret Mead read her book about menopausal zest, as women transition through and some of these changes occur, whether they're on hormones or they don't need hormones, you will find that those memory issues get better, the connectivity, those connections have been made. There's been multiple studies. There was one after COVID that showed that cognitive symptoms were only weakly associated with cognitive performance. And the SWAN study really showed that the cognitive changes that occur around and after menopause are associated with aging and not with the last menstrual period. So the answer is I would expect that the menopause transition is a difficult time for women and the time when you're going to be the most frustrated with your brain. But once you get through that transition, whether or not you're taking hormone therapy, you're going to be right back and probably in one of the most productive times of your life.
And with regard to overall mental well-being, stress, or mood changes during menopause, the question is, can stress or mood changes during menopause worsen any cognitive issues?
So, as you know, many women going through perimenopause and menopause have many responsibilities. It's a time when they often have children who are becoming teenagers or transitioning to college. They may be taking care of aging parents. It's often a time when they have many more responsibilities at work and they're trying to juggle their community, their family, their work, their parents. And so they are stressed. And what we know is that a perimenopausal ovary does not work as well when you're highly stressed, and therefore you're going to have more fluctuating hormones. Fluctuating hormones may be associated with hot flushes, night sweats, mood issues, sleep issues, and all of that is going to affect how well your brain works. And so if you are drinking alcohol because you want to handle the stress, you stop exercising because you just don't have time, all of those things are going to affect how well your total health and also affect your cognition. So absolutely, I think that it's the things that go around the menopause that are what affect your brain and make you feel foggy.
All right, thank you. Our next question is for Dr. Reddick. Should I expect menopausal changes to impact my work performance?
Yeah, what a great question. Dr. Pinkerton already alluded to like all of the uh, life stressors from family to work. ARP actually did a survey in 24, and over 90% of the people they talked to said that their menopausal symptoms had some impact at work. When we look and we ask women, there are many times where they see an impact at work. Happily, we are arriving at a time where you can bring that to your manager or talk, and accommodations can be made. And this varies tremendously from person to person. Some people, it's the vasomotor symptoms, it's the hot flashes, right? And you have to learn some strategies like layered clothing. That may, if you have a workplace that has a required uniform or dress code, that might be something that you have to have that conversation about. I've seen people with their fans or the option to adjust the temperature in their work environment that can help a little bit with those vasomotor symptoms. And then thinking about the fatigue and tiredness, if they're still struggling with sleep, having accommodations to your schedule can make a really big difference where you can stay productive and as well. I want to be careful too to say sometimes people don't have a ton of symptoms, right? They transition through with mild symptoms. And so I don't want to make it sound like every person is going to be impacted both at family and work. But we're happily in a place where people recognize that this is part of a kind of life stage, and we can do things to make that time at work where you stay productive, just like we would make accommodations if you twisted your ankle and you need, a special way to get up and down the stairs while you heal.
That was great. I wanted to add that menopause is not considered a reason for disability, but women who have severe anxiety, depression, that has become less well controlled, and if the accommodations are not working for you, then you may need to seek help. That's often through your primary care, through counseling, or even through seeing psychiatry, because oftentimes when we have mood issues, hormones are not a treatment for depression. They really help they're more of a supplement. So I always think of it as we're tag teaming. The psychiatrist is working to get the moods under control, and we're working on the hormones. We sometimes have unmasking of ADHD, and women who've never really thought that they might have it, or all of a sudden, like, I just can't concentrate, I can't focus. So I do think if you're having severe anxiety or depression, you want to talk to a menopause specialist, but you may also need some extra help. And then I just wanted to mention the labile moods. It's where you're going from happy to sad, but also easy crying. And so I was the first person in our department that went through menopause, and I had a male chair, and I just said, you need a box of Kleenexes in this room, because if you give me good news, I might cry. If you give me bad news, I might cry. If you give me no news at all, I might cry. And it's not because I'm sad or happy, it's just that I'm just overreacting. And as the fluctuating hormones calm down, you become that resilient person again that you always were.
Our next question actually touches on one of the slides that Dr. Pinkerton showed regarding the 6 pillars of brain health, and that is, are there cognitively stimulating activities that will help? And so I just want to take this opportunity to mention the Global Council on Brain Health that was featured on that 6-pillar slide. The Global Council on Brain Health launched just over 10 years ago and brings together the world's experts to address all these different topics of relevance to aging that were outlined in the 6 pillars. And as part of that work, we have a very rich resource library available at the Global Council on BrainHealth.org. I will show you that we have reports. This is one exactly on the topic of cognitively stimulating activities that provides recommendations and practical tips as to how you can keep your mind active in very low budget ways. Everything from stimulating your brain to engaging your brain along with other people for social engagement, using life stages and transitions such as moving or changing careers or retiring as an opportunity to take on new hobbies, perhaps, study something, for example, a new language that you may be interested in, as well as choosing to engage in activities that are both mentally and physically challenging in different environments. So I welcome you to check out those resources, as well as Staying Sharp, which is a tool provided by AARP. On the AARP website, you can check out Staying Sharp. It's an online program offering content about brain health, challenges, even brain-friendly recipes, articles, and activities. I will also add one thing, and that is this webinar is really aligned with a lot of the work that AARP has been engaged in with experts around the world through the Coalition for Women in Brain Health. And so this is a very big priority, and so we really appreciate your engagement, Dr. Pinkerton and Dr. Reddick, as well as all the audience questions that have been coming in. So I'm just going to turn to one of those audience questions that recently came through the chat, which is, I understand current advice is not to start hormone therapy over 60. Is that just oral HRT or transdermal as well? Has there been actual research done?
I can start it. Oh, go ahead.
Okay, go ahead. No, go ahead, Dana.
So I think we hit the slide. I always say that we take care of people, not guidelines, right? The guidelines are helpful to us because we can present a consensus of evidence-based data. And so the idea that you would initiate therapy within 10 years of menopause or over 60 fits with the best evidence. But depending on a person, there may be reasons that you think about outside of those guidelines. But in general, you're going to be starting before 60 or within 10 years if someone's still having persistent symptoms that you think the hormone therapy would be helpful for. And then I feel like there was a second part to that question.
Well, and would transdermal be better?
Right.
So I think the issue is, The hard data that we have is on an oral standard dose conjugated equine estrogen, a synthetic progestin. And it had the risk, they were rare, absolute risk, but very rare in young, healthy women and not so rare in aging women. And that's where that differential line was drawn, but it's not a line in the sand. So we've had internists who say, oh, you're 60, you have to stop your hormones. That's never been said by the Menopause Society. What they've said is you need to keep reevaluating each year to determine why you're doing it, what are the risks of doing it. But your real question is for the groups of women who, because the WHI never took hormone therapy and now feel like they've missed out, or are having persistent symptoms or now have bone loss and feel that they want to have a trial of hormone therapy, will we discuss it? Yes, menopause certified practitioners will talk about it. We will not tell you that there's not any risk because we don't really know what the risks are with these new low dose patches, gels, rings, and with progesterone, which is, what your body used to make. It's a gray area where we don't have good science. I personally am concerned when people are on long-term hormone therapy because I do worry that it might increase the risk of breast cancer based on some of the studies. And truthfully, if you are diagnosed with breast cancer as you age and you're on hormones, we take away your hormones and we put you on an anti-estrogen. But if you're 60 and you're healthy and you have a reason you want to think about hormones and you are, meeting a hard line, I would say go to menopause.org, look at the section for women, then look at the zip code, put your zip code in and find a menopause certified practitioner who is going to be much more likely to know all the data and be more willing to have a conversation about risks and benefits for an individual.
Our next question. Oh, sorry. Did you have something else?
My only follow-up was just to add that there are treatments that help with menopausal symptoms that aren't hormones. And so that is the other advantage of working with someone who has experience in this area is the ability to, if this doesn't work or you're not a candidate, I've got several other things that I have experience with that can help patients.
And the exciting new information is that we have 3 FDA approved non-hormone treatments that are effective for hot flushes. The 2 newer ones actually work in the brain on your neurokinin receptors to stop they antagonize the receptor and therefore decrease the hot flushes, but they also improve sleep. And the newer one, elinzanetant, works through 2 neurons to block them, NK1 and NK3, and we see improvement in hot flushes, sleep, and mood. So we do have options for women who either aren't candidates or need to stop and have persistent symptoms because 6 to 8% of women continue having hot flushes into their 70s and even into their 80s. Alas.
Our next question really points to the ambiguity around what may be happening and where people are in their menopause journey. That is, how do we know where we are when every other month is a surprise that, period or no period? It's a very distressing, confusing time for many people against a backdrop of a lot of headlines coming out, of course, about do this, do that. What do you advise when people are just trying to gauge where they're at?
Yeah, I think I always start the perimenopause time is the hardest time to treat and sometimes the most symptomatic. You're in menopause when you've gone a full year without a period. If you're still menstruating kind of here and kind of there, then you're not fully in menopause yet. But that doesn't mean you aren't having all the symptoms. And so that's the time where maybe we're not doing the classic menopause hormone therapy or what people would say hormone replacement. Maybe we're using different hormone combinations to help regulate your periods. For some people, that's birth control pills. For other folks, that's estrogen, progesterone in a variety of combinations where we can either suppress your menses or we can get them back on a regular pattern that's predictable until you're fully in menopause.
I think it's also important to recognize perimenopause is much harder than menopause. And that's also where the changes are happening. We actually find that you are starting to lose bone density and have changes in your cholesterol in the 1 to 2 years before the final menstrual period. So for women who are perimenopausal, there's a lot of gadgets out there. Tracking your periods, tracking your symptoms, probably worthwhile. Getting blood work every 3 months, probably not worthwhile, because you're going to fluctuate in your hormones. Finding somebody who's going to listen to you, help you figure out what your symptoms are and how to help navigate is what's really most important. And so for some women, it's going to be headaches, it's going to be mood, it's going to be erratic periods. Heavy periods, birth control pills, even a progestin IUD might help. And we do sometimes supplement with hormones, and they do seem to help many women, with the caveat that your hormones are going like this. Your hormones are going up and down, cycle to cycle, and even within the cycle. And that's what makes it so hard. And then once you get through to menopause, when your ovary is quiet, although it might still sputter some, but mostly quiet, it's a lot easier to get you on one standard dose and to feel like you're yourself again.
Our next question addresses the topic of sensory health. Can menopause have an effect on, for example, eyesight or eye focus?
I was going to say the challenge here is that the time of menopause is also the time where we see a lot of changes in vision. So the reading glasses come out around that time. And so I do encourage my patients, just same way that you want to have your hearing checked and your eye checked and see the dentist, that those need to be followed as well.
There isn't any evidence that taking estrogen is going to prevent the eye changes of age from happening. It's not going to prevent cataracts. It's not going to prevent macular degeneration. It doesn't treat dry eyes. You're going to have to do just like Dr. Reddick said, having your eyes checked. They are going to change, but hormone therapy is not a magic answer. It's also not a magic answer for weight. We haven't really talked about that, but many, many women start having that increase in weight, 5 to 10 pounds, happening during the perimenopause. We know it's a metabolic issue, and it doesn't happen to all women, but it is definitely that and loss of libido, probably two of the most common complaints that we have outside of the traditional menopause symptoms that we've talked about.
So as we approach 7 p.m., I think we have time for one more question, and I think it actually relates to that last point that you mentioned, and that is, this viewer says, it seems like so many people are pushing hormone therapy. If you opt not to do it, is it possible to still be healthy as long as you are exercising, eating well, etc.? So I think really pointing to the lifestyle factors that you just mentioned.
I'm going to take a first stab at that. A healthy lifestyle is without a doubt the most important thing that you do. And exercise, including strength training, are the pillars to longevity, along with sleep. And so those are going to be the most important things. Some women just sail through menopause. They never have a hot flush. They never have a night sweat. Their periods just stop. They they get calcium in their diet. They get vitamin D. They exercise, maintain their bone density. Do they need to be on hormones? We don't think so. But for the highly symptomatic women, those are the ones that we think about it.
Absolutely. I hear here. I think there's so much conversation on the internet and social media and friends talking that people feel like they're somehow missing the boat if they're not taking hormones. And I think it goes back to what we said before, like this lifestyle, a general focus on health is going to help you through the menopausal transition. It's going to help you after the menopausal transition. And we would do hormones just to treat symptoms. With the caveat that it can help with bone loss, but there are other strength training and other things that we could be helpful for, but it's okay not to take hormones.
So when you leave this symposium and you walk out and you go, I don't remember a thing they said, that's not what I want you to do. I want you to talk to a friend and say, this is what I learned. I need to sleep. I need to exercise. I need to learn new things. I need to make connections, because it's the C1 do one, teach one. Remember that teach part. If we can get the knowledge out about how to help maintain your brain at menopause, after menopause, then this will have been worthwhile for all of us.
Well, I think that's an excellent note to close on, and I really want to thank you for highlighting all the different 6 pillars, for example, that we can organize a lot of our thinking and prioritization around. Again, if you want to explore different infographics, reports, I encourage all of you to check out the Global Council on Brain Health resource library on the AARP website. There you can find those practical tips and recommendations around the topics, for example, nutrition, physical activity, sleep, etc. We also address fun topics like the effects of music on the brain. And of course, Staying Sharp is another really helpful resource that can help motivate you to hopefully engage socially and keep your brain healthy as you age. So I'm going to turn it back to my colleague, Jared, in the AARP Virginia office. And thank you again, Dr. Pinkerton and Dr. Reddick.
Yeah, thank you, Lindsay, for hosting us here tonight, and Dr. Reddick and Dr. Pinkerton. That was fabulous. We really appreciate your time. Thank you to everyone for joining us this evening. You'll be receiving a follow-up email with some helpful resources. If you had a question that you put in the chat that we didn't have time to answer tonight, I apologize. Please reach out and let us know, and we can try to get you an answer and follow back up with you because we know this is really an important topic. So thank you, everyone. Have a wonderful evening.
And thank you, AARP, for hosting this. It's a great conference. Thank you.
Happy to do it. Bye-bye.